on the image that is picked up by the camera, and also this camera picks up the image of the head and also that of the coil, and it superimposes on the functional MRI, and it helps to navigate the system. That is like stereotaxic effect. So the other form of non-invasive brain stimulation that I was talking about is the transcranial direct current stimulation, in which 2 electrodes are placed, around 5 centimeter sized electrodes, which are soaked in saline and are placed on the, one electrode is placed over the cortical region or the anatomical area of the scalp, which needs to be stimulated, like the motor cortex in reference, just as I said before, over the M1 region or wherever you want it. And the other is placed on the contralateral side on the supraorbital region. And either of them can be changed into the anode or the cathode. Like the anode usually is excitatory and the cathode is inhibitory. And therefore you can change whether you want to stimulate that aspect of the brain or inhibit that aspect of the brain. You can change the direction of the current and thereby give the stimulus. Again, low duration intensity is given, that is around 1 to 2 milliamperes current is passed, again for 25 to 30 minutes. The advantage of this setup is, as the stimulus is given, the patient can do some activity or a therapy, for example, hand therapy. So there is a synergistic effect of the physiotherapy, that is the movement therapy that the patient performs, as well as the direct current stimulation. In fact, this is the modality which is most commonly used in many of the PMR groups in the United States, whereas the TMS is mostly under research, since there is not much evidence has still been generated. Is there any difference between the two? Yes, there is a minor difference. One, here the weak electric field is formed, but it has a deeper effect. That is the current, direct current stimulation. When compared to the TMS, it has a strong electric field, but it only has a superficial effect. But what is happening inside the brain? The mechanism of action is through the long-term potentiation or the long-term depression. This depends upon the type of receptors that are stimulated, but not exactly the type of receptors. Even with the same receptor, you can see glutamate, NMDA, or for example, the dopamine D1 and the dopamine D1. Both are the same receptor that is stimulated, but the outcome is different. And this happens because there is a postsynaptic calcium influx, which can be either fast or slow, depending upon how you are stimulating the brain. That is, whether it is intermittent, continuous, or theta burst exactly. And depending upon whether it is a rapid influx it reaches, if there is a rapid influx of the postsynaptic calcium, it then goes in contact with the C terminal of the calmodulin complex and thereby activating the kinase pathway and thereby potentiating the increase in the AMPA receptors and leads to long-term potentiation. And whereas the reverse is true for long-term depression. The mechanism same for TMS as well as direct current stimulation. Are there any adverse effects? The adverse effects are mostly minimal and also temporary. And in direct current stimulation, as expected, some itching is seen, irritation is seen, whereas in the TMS, it's mostly headache, neck pain, cognitive effects, etc. But no significant seizures have been affected. This was a study that was planned in research lab. Unfortunately, I do not have the results of this study. Probably in the next conference, I will to share it. And in which we planned in chronic low back pain patients, the TMS intervention in the first 4 weeks, and we are looking at what it changes in the corticomotor excitability, thereby changing whether it is crossing any neuroplasticity effects in a patient with refractory chronic low back pain. I will briefly touch upon the spinal cord stimulation because this has been dealt in detail in the previous session by Dr. Sumalata. Basically, it has an electrode which causes stimulation. The stimulation parameters vary depending upon whether you want to use it for pain or you want to use it for locomotion. So what exactly for the pain? You are aware of the gate theory. It happens by the gate theory. And this was brought up by Dr. Abhishek also when the lecture was going on. The transcranial stimulation is now coming into more and more research, and in which the cathodes are placed at the C3, C6 level or at the T11, L1 level, and the anodes are placed at the anteriorly at the iliac crest level. And transcranial stimulation, how it works is that here the intensities are larger, and thereby when the dorsal root horn is stimulated, and through the interneurons, the motor neuron is also getting stimulated. And also these interneurons move up and down, and thereby it helps in spreading that electrical current all along the spinal cord. So this was one of the first few studies which found that when a stimulation of the spinal cord is occurring at the T11, L1 level, this kind of rhythmic contraction of the muscles through the EMG, this was just EMG pickup, not the movement exactly, in a spinal cord injury patient. And even though the stimulus was constant, why the rhythmic pattern is happening, that was what led to the discovery of what is known as CPG, or the pattern generators, or the locomotor pattern generators, or the central pattern generators. And this is the theory behind the use in spinal cord injury. So the parameters will vary for transcranial magnetic stimulation. Basically, there are two different types of frequencies, that is unmodulated and modulated. The modulated has a carrier frequency so that it brings about the same effect of stimulation, that outcome, but at a lesser amplitude, and thereby the patient will not be able to perceive the pain, or rather will be able to tolerate the pain. The adverse effect is that when you stimulate it along with locomotion or any stimulation of the muscles, it can also cause voiding, and if the patient is susceptible for ADs, then he may also have some symptoms of ADs. The clinical application, now coming to how we use the neuromodulation clinical application, it is used in stroke, which is seen in the subsequent topic. We have to be careful about the patient selection criteria, whom to include, whether they are able to participate in the rehab, whom to exclude, like for example, pregnant patients, those who have cardiac pacemakers, etc., will help you to identify the patients. Then in chronic pain, just as that, we also studied the different parameters and the location are used depending upon the condition for fibromyalgia, headache, low back pain, chronic pain, or trigeminal neuralgia. Depending upon the location and the intensity, again, I said the resting membrane, resting threshold, motor threshold is used to calculate what stimulus needs to be applied. These are based upon the previous studies. None of this is the indication for clinical use presently. This is what the previous studies had used, which we can further study further to see whether they are actually useful. Again, in spinal cord injury, it has also been studied. This is one study we did. We used neuromodulation of the tibial nerve by using just a TENS machine, and we compared it with oxybutynin, in which we found comparable efficacy. To summarize, presently the TMS is indicated and approved for uses like tremors in Parkinson's disease and in many psychiatric conditions like depression and also. And only the epidural spinal cord stimulator is presently approved for use in pain. A lot of research is being done experimentally for the improvement in motor function, sensory, memory function in cases like stroke or traumatic brain injury, and also in disorders of consciousness. Thank you.
Thank you, Dr. Srikumar.
Thank you, sir.
The floor is open for questions.
Sir.
Yes? Mike, please.
Sir. Thank you, sir.
I would like to know for the pain conditions using TMS, for regional pain conditions.
Okay.
If you have been using for how long?
No, we are not using it. As I said, this is being used for only investigational purposes. We are not giving it as a treatment for the patients. We are only using it as a research. For example, in fibromyalgia, we have one project going on. In chronic low back pain, we have one project going on, which is almost finished. Soon we'll be able to publish it. And also one in spinal cord injury is going on, but I am not handling it. It is under Professor Geeta Handa. We are just studying the investigational use of this.
All right, the duration, I would like to know
the duration ranges, that is what I was saying. The
sessions.
duration is up to, repetitive TMS when you use, it goes up to 20 to 30 minutes. If it is theta burst, it can limit it to 10 to 15 minutes.
Sorry, I would like to know the number of sessions.
Number of sessions, yeah. We usually give it multiple sessions over a week, like up to at least 4 weeks period. Up to 6 sessions.
How many sessions per week?
Yeah, up to 6 sessions per week.
Thank you.
Yeah. That is for study purposes again.
Coming to Dr. Nurul's question, I think TMS right now has been established in a lot of psychiatric conditions.
Psychiatric.
So if you look at the pain conditions which are being advocated, most of them have a psychological component of depression and like fibromyalgia, and most of these conditions have a psychological component. And probably that is one of the mechanisms through which TMS works in fibromyalgia and myofascial pain.
So how we go negate it is by doing a proper study design.
Yeah.
So when you have the study design, we randomize control, and we also manage the patient similarly, and we yet see it is only a proper study design that can answer this question, whether it is having only the cycle.
Exactly.
Thank you, sir.
Thank you. Thank you, Dr. Srikumar.
Thank you, sir.
Our next speaker will be Dr. Mohit, Associate Professor, All India Institute of Medical Sciences, Kalyani. He will be talking on the role of RTMS in cerebrovascular accident rehabilitation.
Thank you very much. My topic is role of RTMS in stroke rehabilitation. This is my institute where I'm working. As we all know, stroke is ranked the second most leading cause of mortality worldwide, and it causes severe morbidity in its survival. So, the number of patients with severe upper limb hemiparesis has been declining with the introduction of rehabilitation, but even with the rehabilitation, less than 50% of the patients are able to use their hand properly. So RTMS is a upcoming treatment method which is applied to bring out the potential of brain reorganizations by directly stimulating the cerebral cortex. RTMS has been widely adopted as a treatment strategy in mainly psychiatric conditions like depressions, OCD, and some neurological conditions like stroke, Parkinson's. Low frequency RTMS leads to lasting reduction in cortical excitability in the motor cortex. Strategy being, we applied in the unilateral stroke patients targeting the primary motor cortex contralateral to the affected cortex spinal tract based upon the interhemispheric inhibitions. I am not going to details as my previous already speaker. So basic principle is the Faraday law of electromagnetic induction. When we applied this figure of 8 coil, during the electric conduction, the electromagnetic waves are generated just perpendicular to it, traverse the scalp, cerebral cortex, and a eddy current is generated just perpendicular to it, which ultimately leads to stimulation of the interneurons and corticospinal tracts, which ultimately leads to brain plasticity. If he uses the high frequency RTMS, it causes long-term potentiation, and on the other hand, if he uses low frequency, it causes long-term depression. And this is mediated by the GABA. So, activation of glutamate system enhances the brain plasticity, and activation of GABA decreases the brain plasticity. Now, what are the effects we expected? Conventional low-frequency RTMS can lead to modest to short-term benefit on motor functions of the paralytic hand, and complex motor skills, such as those performed by the hand and wrist, improve significantly with the low-frequency RTMS. And in case of lower limb, there is studies found that reduction in the spasticities. As per studies, it is shown that RTMS increases the brain plasticity, and that to be optimal if combined with the intensive rehabilitation. So the combination of RTMS and intensive rehabilitation enhances the beneficial effect of each intervention procedure. Now, details of the procedure, we are using the figure of 8 coil, stimulation site being the primary motor hand area. We are using the low intensity RTMS. In the unaffected side, we given the each session for 20 minutes for 2 weeks. So before starting the RTMS, we first initially have to check what is the MEP for the patient. So with the use of this figure of 8 coil, we are generating the what is the MEP for the patients. So we have placed this figure of 8 coil in the cerebral cortex. Impulses are generated. We are observing for the any contraction in the first dorsal interossei, but we are not observing. We have initially given for 10 pulses. We are not seeing any contraction in the first dorsal interossei. As no contraction are seen, we gradually increases the intensity by 5%. Now, after a certain time, we are observing the contraction in the first dorsal interossei. So we have, by titrating, we have set the what is the MEP for the patients. So after deciding the MEP, we now place the value in the machine. We first set to repetitive mode. We first set the frequency to low frequency. We set it to 1 Hz. The MEP is already set 57%. We set to 1 Hz. Then we set the train of frequency. we set to 60. Now our machine is ready to run. After setting all the value, we start the therapy. Impulse is generated and transmitted to the cerebral cortex. Patient is getting the stimulation in comfortable position. The session is run for 20 minutes. We are giving 5 days in a week for consecutive 2 weeks. We start from Monday to Friday, Saturday, Sunday break, then again Monday to Friday. So total 2 weeks therapy was given. Apart from RTMS, we continue the physical therapy for the patient, both active and passively by the physiotherapist. We also treat the caregiver. We continue the occupational therapy for the patients. We assess the patient with Figel assessment score for both upper limb on time of admission and after 2 weeks of therapy. We observe there are much reductions in the spasticity and increase in the range of motions of shoulders and elbow. But we have not observed much improvement in the lower extremities. So, this is the gait pattern of the patient before starting the therapy. We are seeing the much spasticity in the upper limbs and the lower limbs. She barely able to manage her gait. After 2 weeks of therapy, the spasticity in the upper limbs much reduced. He was able to manage his gait. And this is the gait of the pattern just here 2 days back. We observed that the same is persistent even after the therapy. As per literature support, apart from the major seizure side effect, some patient experiences headache and fatigue, but no serious convulsive seizures are reported. It is found that low frequency RTMS is superior than high frequency, and the main thing is that the effect is mainly depends upon the site of stimulations, the method, lesions, and interventions time. If you come with the RTMS with the lower limb, the basic two difference. First is the difference in the localization between the lower and the upper limb region, as known as pain-filled homunculus and the nerve fiber that does not cause the obstruction. As in the picture, it is obvious that for the repression of the lower limb, it is much deeper in the cerebral cortex, so we require a special type of coil for the approaching the lower limbs. Now, RTMS in aphasia, as per literature, the therapeutic window for rehabilitation intervention is much wide. So we can approach the patient with even 1 year, 2 year post-stroke. So chronic aphasia, for several years, even after stroke, there is a possibility that language function will be recovered by conducting appropriate rehabilitation. So the recommendation therapy is again low frequency RTMS reduces the interhemispheric innervations of the left hemisphere by inhibiting the effect on unusually high activation levels of the right frontal lobe. So, as per study, Nisar et al. Applied the low frequency RTMS for 10 days in the inferior frontal gyrus of the right frontal lobe. As a result, it was found that patients are able to recall the name of more objects than before the treatment. So, this is the patient with history of repeated stroke, reported to our OPD. Her main concern is the speech. Given the RTMS, we observe much improvement in the speech, and as she is Anganwadi worker, she can able to take classes with better speech. To conclude, neurorehabilitation through RTMS is a treatment modality by evidence-based guideline regarding the use of post-stroke motor impairment, hand and wrist motor recovery, and chronic non-fluent aphasia. RTMS has shown benefit in stroke rehabilitation, but with limited evidence and a high degree of protocol heterogeneity. So more core studies are required to assess the effect of RTMS. These are my references. Thank you for listening.
Thank you, Dr. Mohit. The floor is open to questions. Mike, please.
Thank you, sir. Sir. Sir, can you please speak in the mic, sir?
Case of cerebral palsy patient, it's hemiplegic, it's
Yes, sir.
variety.
According to literature, there is a evidence that it can reduce the spasticity even with the cerebral palsy patient, but question is that patient should able to sit in the instrument, able to bear the stimulation, because it has a special sound. So some studies show that if the CP child, the child is too small, not mentally adequate, then get problems. And main thing that we have to further titrate the dose, the MEP, otherwise there is chance of convulsion. So that patient has to cooperative. So that is the main problem with the CP child.
Okay, thank you.
Sir.
Are you using it part of a study protocol or purely for treatment?
Sir, we are giving the treatment and also it is a part of studies, sir.
What is the current level of evidence for motor and aphasia post-stroke?
Sir?
What is the current level of evidence of RTMS for motor recovery and for speech language
Sir,
recovery?
I'm not sure, but some studies have found that in the aphasia there is much improvement. So this patient that was shown is reported to us, and she has a history of 2 or 3 times the strokes. So when she came to us, her main complaint is the speech problem. So we tried this, and there's a much improvement in the speech. So as she is an Anganwadi worker, she has to talk with the child. So she was.
It's not approved for treatment. Please use it as an investigative protocol only, right? That's what I'm trying to
Sir.
say.
Dr. Mohit, have you encountered any complications? And
No,
are
we
you
have not.
following any prophylaxis for seizure?
We have used a midazolam spray as a prophylaxis, but we have not encountered any complications.
Thank you.
Thank you, Dr. Mohit. Actually, I just a quick addition. We have been using RTMS in Royal Care for past 3 months, and we have been not as a research, but for patients. We have completed nearly 300 patient sessions. So from the whatever we have done, I understand that it is a really promising stroke in stroke, and we have had good results in even chronic stroke for spasticity reduction. And even I have tried for patients with S1 stimulation also, which has increased your increased the sensation of the patients also. Third is regarding aphasia also. I have had 2 or 3 patients with better speaking ability after RTMS. And then pain management. My experience is that the post-stroke pain, that is the patient doesn't even allow you to touch the hand. It is significantly reduces with RTMS. So what I say is, I feel is, though we say that there is no much evidence it's coming up, surely we will be able to bring up more evidence, and we are working on the multicentric trials now. So it is a very good addition. That's what I'm saying. And we are doing it for traumatic brain patients also.
Thank you very much. Even the patient that I have shown here, there's a much improvement in the cognitive function also. We are checking with the software.
So one comment about Nurul asked about CRPS, right? So it is moderate evidence for using it in CRPS on contralateral cortex, and the mechanism is it causes NMDA receptor. It acts as an NMDA receptor antagonist, and it causes central desensitization. This is how it works in CRPS in pain. That's what I wanted to add. Thanks.
Thank you. We thank all the speakers for having taken us to a journey on neurorehabilitation, right from the basics of neurophysiological approaches to the new promises in neuromodulation. I request all the speakers to please come to the stage. Dr. Sandeep, Dr. Abhishek, Dr. Srikumar.
So thank you, sir. Now I request Senior Physiatrist Ramachandran sir to honor the chairpersons, Dr. Edmund Digato and Dr. T.J. Ranganathan sir. So thank you, Dr. Ramachandran sir. Thank you, Dr. Edmund sir. Thank you, Dr. T.J. Ranganathan sir. So it's time to break for lunch and reassemble in the same place sharply at 2 o'clock, 2 p.m. Thank you.